Hi everyone, welcome back to Face It with Dr. G. I'm Dr. G and I'm so excited to be back again. We have a really amazing topic today and I just want to say thank you for all the incredible feedback on social media, on Instagram, on TikTok with responses to this podcast, and I'm super excited. We've had hundreds and hundreds and hundreds of downloads, and so I'm just thrilled. So let's get into it. We're going to talk about rosacea today, and as many of you are aware, maybe you're not, it's a multifactorial disease and skin condition, and it causes significant stress in patients and individuals. Treatment needs to be considered a spectrum versus treating the type. And I'll get into that a little bit more, but let's think of this as a spectrum, a process that will likely require both lifestyle modifications and medical intervention. And I'm going to get into the nitty-gritty of the molecular aspect of it, specifically why neuromodulators or neurotoxins such as Botox, Dysport, Xeomin, can be effective in treating rosacea. As I mentioned, there are 4 types of rosacea. We have the mild form, which is the erythematotelangiectatic variant. It has redness, erythematous. Telangiectatic is broken blood vessels. So that's where you see patients that have mid-facial or central cheek redness and telangiectatic vessels or broken blood vessels that can get worse with red wine and alcohol, sweating, exercise, heat. Then, and stress. Then you have the papulopustular variant where you get little papules or little bumps and little pustules that can be whiteheads. And then you can get the phymatous or phymatous variant, which is specifically the nose that's affected. And you can also have ocular rosacea. So understanding these 4 subtypes is critical, but also it's more critical to understand that we should look at this as the patient as an individual that has different aspects and qualities of their life that contribute to their rosacea and treating it appropriately. So we are now finding that rosacea has many different aspects to it. So there's dysregulation of the innate immune system. There is abnormal neurovascular signaling. So neuro meaning neurons, the neural system, and vascular meaning the vessels. And then there's also a problem with the skin microbiome. So let's get into this. Rosacea is linked to both mast cells that are part of the innate immune system and the antimicrobial peptide cathelicidin, also known as LL37. What are cathelicidins? They're small, positively or cationically charged peptides that are composed of up to 97 amino acids, and they are produced directly by the mast cells. So, cathelicidin, we're going to talk about the specific cathelicidin in this podcast that we're dealing with as LL37. Cathelicidin LL37 comes from the mast cell. Okay. So LL37 is antimicrobial, but is also involved in angiogenesis, the production of extracellular matrix proteins that comprise our dermis, and also chemostasis of leukocytes. So chemostasis means the recruitment and traveling of white blood cells, also known as leukocytes, to an area, the targeted area, whatever that may be, a wound or inflammation or whatever that may be. And this chemostasis also includes mast cells. So not only are we now seeing that rosacea is directly linked to mast cells in a way I haven't gotten into yet, but the LL37 cathelicidin that's produced by mast cells also recruits more mast cells. Okay. LL37 also induces cytokine release and degranulation of all these little granules in a mast cell. Okay, so let's dig deeper into what is a mast cell. Okay, so coming from a dermatopathologist, or dermatopathologist is what people like to say, a mast cell is that really pretty pink cell under the microscope. It's bright pink, and it has up to 100 large granules inside the cell, and when you stain these cells with different enzymes to highlight them under the microscope, they're bright pink. So what are in these granules? So mast cells contain things like heparin and tryptase and growth factors. And what happens is essentially you can measure the number of mast cells in the skin. And mast cells can be increased due to an allergic reaction, or they can be generally increased because of a condition called mastocytosis, where you just have an increased number of mast cells in your skin. The enzyme tryptase in a mast cell is one of those enzymes that's extremely specific for a mast cell. So when we have to diagnose these conditions under the microscope, you stain them for tryptase because it's really specific versus sensitivity, where sensitivity has, you'll catch more of a variety of things, more cells, it's more sensitive, less specific. This is really specific. So you are very sure that you are highlighting only a mast cell. So the other thing that tryptase does is it actually activates fibroblasts and it helps with their proliferation. So now we know that mast cells have this enzyme tryptase, and that helps with proliferation of fibroblasts, which then produce collagen. So they help with the production of type 1 collagen, and we love that. So now that we know a little bit more about the mast cell, I'll give you a little bit of an overview or a summary. It's part of our innate immune system. It has a bunch of these bright pink granules in it. It's involved in the proliferation of fibroblasts. It's involved in allergic reactions. And when you have allergic reactions and those granules degranulate and you release histamine and other factors, you recruit more mast cells to the area. So I think it's important that we understand what this cell is. Now let's get back to that cathelicidin that we were talking about, that amazing peptide full and made of amino acids that is produced by mast cells. So why do we really care, and where is that made, and how is it made? Cathelicidin is actually created in humans as an inactive propeptide. And what that means is it has to be activated somehow. And usually that's by being cleaved by an enzyme. So cathelicidin, LL37, is cleaved by KLK5, or kallikrein-related peptidase 5. And when it's cleaved by KLK5, it's actually then active. And when LL37 is active, that's when it is involved in creating that redness and inflammation in rosacea. So we want to stop that process, right? So how do we decrease the amount of active LL37? Well, somehow we inhibit the KLK, kallikrein-related peptidase. That's actually what doxycycline does. That's why doxycycline, the antibiotic, works in rosacea, is because it inhibits KLK. So hopefully that tied some different concepts together for you in your head. Okay, so let's get to the point that you guys care so much about and why you're listening or watching this. So patients that are have refractory rosacea have been shown to benefit from neuromodulator, neurotoxin, aka Botox, Dysport, Xeomin, Jeuveau injections intradermally to decrease the signs and symptoms of rosacea. So how does this happen? We have realized that BONT-A, or onabotulinum toxin A and B, inhibit the release of acetylcholine from the presynaptic neuron, which we know, and that's why we use it to decrease that muscle activity. But it's also been shown to decrease the release of other chemicals, such as calcitonin-related peptide and vasoactive intestinal peptide. Both of these, actually, the acetylcholine and the VIP, vasoactive intestinal peptide, have been shown to be causative factors in erythema and flushing in rosacea. So why do we care? We care because by blocking the release of these two substances, you then decrease that erythema and flushing that we don't want. And what we found is that if you guys have listened to other podcasts I've done or educated yourself on how onabotulinum toxins A and B work, you know that it works by cleaving SNAP25, which is a snare protein. And what we found is that mast cells also have that same snare complex and SNAP25 that the neurons do. So that BONT-A or BONT-B works the same exact way as it does at the synapse or the presynaptic terminal on the mast cell. It cleaves SNAP25. Wow, this is amazing. So then you don't get the fusion of the vesicles to the membrane, those big hot pink vesicles full of all the hot pink granules of the mast cell. You don't get fusion and degranulation. And that's why we've seen that we don't have the erythema and the flushing in rosacea. The other interesting thing is that it is dose dependent, just like we see when we're doing our injections in the face for facial movement or anywhere else in the body with onabotulinum toxin A. It is dose dependent, so the higher the dose, the less mast cell degranulation you observe. So, all in all, I hope you take away several key concepts here, that rosacea is a very overwhelming skin condition that affects patients psychologically, it affects their lifestyle, and it affects their self-confidence. And so how do we correctly treat them? You have to understand the different subtypes, but also how to approach them and what's happening under the skin. So remember LL37, the cathelicidin, remember mast cells, and remember that our Botox, Dysport, Xeomin, and Jeuveau works the same way on mast cells to prevent degranulation as it does when we're injecting, for example, the glabella or the forehead. It works by cleaving SNAP25, and I think that's so cool. I hope this empowers you to go read more about what mast cells do. They have so many functions and purposes in our bodies. Maybe you'll even look up what they look like under the microscope. I wish I could show you. And I hope you guys have a great day. I hope you learned something awesome. Like, share, subscribe, talk about it, tell your friends, talk about mast cells because they're really fun and pretty. And I hope to see you guys again soon.